Well, good evening, everyone, and welcome to another edition of the RX Question Lab. Tonight, we are going to be tackling cardiovascular. Let me share my screen here. There we go. For some of you regulars out there, I know it's been a while. For all you newbies, welcome aboard. It's fantastic to have all of you with us. Tonight we're going to delve into the complexities of cardiology. It's a key area of knowledge for any physician, anyone who's getting ready for STEP. My name is Jeff Downing, and I'm delighted to be your host for this return to Q Lab. Tonight we're going to navigate some of these intricate pathways of cardio health, disease, and treatment, and we're gonna dive into these board style questions, work to illuminate some of the key concepts, and hopefully provide you with some tools and tips needed to answer some of these challenging items. Tonight, I am joined by my special co-host, Dr. Abraham Titus. Abraham, would you mind introducing yourself to the crowd?
Sure. Thank you, Jeff. Well, my name is Abraham. I'm currently a hematology oncology fellow at the University of South Alabama. I've been a tutor with RX for the past, I'd say, 4.5, almost 5 years now, and have taught many students such as yourself achieve their goals on their step 1, step 2, and even step 3. And I'm happy to be here. Excited to go over one of the most high yield topics in USMLE, cardiology, and again, we're kind of taking the questions-based approach, which Jeff will talk about a little bit more.
Excellent. Thank you, Abraham. And we're also joined by Kate, and she's going to be in the background here answering questions in the question box. So head over to the question box if you've got questions, comments, feedback throughout the night. And together we're going to try to guide you through the world of cardio. Again, for us, we believe that answering board style questions is probably the highest yield activity you can do when studying for STEP. So we also know that these questions can be very challenging, and without the right approach, they can seem insurmountable. So that's where we come in. Our mission is to really help you develop some of the skills to dissect these questions and to do it effectively and efficiently, which is, you've got to be able to do it pretty quickly, right? So what we're going to do is we're going to break these questions down together, and we're going to try to do that all here in real time. So, but before we get started, I do want to learn a little bit about you. So what I'm going to do is I'm going to launch the first poll of the night, and this is going to be the easiest question by far. Let us know, who are you? Are you M1, M2, M3, M4? Are you maybe you're an IMG or an FMG? Okay, so looks like most of you have voted, so I'm going to close the poll, and we're going to share the results. So tonight we've got a good IMG and FMG contingent. Looks like about 2/3 of you. And about 1/5 of you are M2s, but we also have some M3s, M4s, and a few M1s in the crowd. So this is great. So good to see you. I'd love it as well if you want to just go in to the question box, let us know where you're tuning in from. With Question Lab, we always bring in students that are studying from around the world. So let us know where you are, where you're joining us tonight. Okay, so again, grab your notes, open your minds, and let's get ready for a productive session. One note, we will have a raffle at the end of tonight's event, so you do need to be present in order to win, and we'll also have a special offer. Okay, so with that, let us go ahead and go to our first question. And again, if you're new to Question Lab, we just want to underscore that part of this is, we want to help you learn how to answer cardio questions, but we also want you to to think about your methodology. How are you going to answer questions on game day, right? When you step into the exam center, how are you going to do it? And so, for us, we recommend a stepwise approach to answering these questions. And so, as we go through these items tonight, we're going to follow the method that we teach. Now, you don't have to use this approach. You can have your own. But I think the key thing is you need to have an approach that you can practice over time, right? So that you're not thinking about these different things, and that you're, again, as efficient as possible when you are when you're answering questions. Okay, so just keep that in mind, and think about that as we start with question number 1. Now, what's missing? Right? You're looking at this question, you're going, seem to be lacking something. Well, that's step 1 for us. We say cover up the answer choices. Okay, so step 1, we say cover up the answer choices, and the reason is, when you're, in a high pressure situation and you're looking at these questions, you've got a lot of things coming at you. We want you to be able to sort of, control the environment. And sometimes you're going to see, answer choices for topics or things that you either don't remember, or you don't remember if you remember. So what we want you to do is we want you to first cover up the answer choices. And then number 2, we want you to go through and we want you to read the lead in, and that is the question, right? So if you go in and read the vignette, which is the little scenario at the beginning, you'll learn about the story, you'll learn about the patient, but by reading the lead in first, you'll be able to focus on what kind of information you should be looking for, or what is it that is at the core of what you need to figure out. Okay, so again, step 1, we cover up the answer choices. Step 2, we read the lead in. In this case, it is, which of the following coronary arteries is most likely occluded in this patient? Okay. And obviously in this question, you've got an ECG. So again, you've got a little bit of data before you even read the vignette. Okay. So let's read the vignette. A 58-year-old man comes to the emergency department because of chest pain and shortness of breath for the past hour. The patient appears to be in acute distress. The ECG is shown. So again, which of the following coronary arteries is most likely occluded in this patient? Feel free to go down to the question box. Let us know how many steps you think it's going to take to answer this one as I pass it over to Abraham.
All right, so this is kind of a classic cardiology question. There are not many EKGs that we do need to know for step 1, but there are a few that are standard that you must know, must not miss, and must recognize. So what we'd like to do is go through the question, highlight some keywords that are kind of important, and kind of set up our thought process in order to answer this question. So here, as you can see highlighted, the word coronary arteries is important because that's kind of what we're looking for. It's not just asking you what's the diagnosis, it's asking what the coronary artery is most likely occluded in this patient. And then when I look at the actual question itself, chest pain, shortness of breath for the past hour, right? So many differentials should come to your mind. And in this situation, with the EKG, there should really be only one diagnosis that is overlying. And if I look at the EKG, there's obviously a method to the madness when it comes to EKG, and there's a whole talk we can do about how to go about it. But there's one thing that kind of blares and that kind of sticks out to you, and that you shouldn't be missing when you do look at an EKG. And this is something that you'll be tested on for the rest of your lives, especially if you're staying within the internal medicine category. So, now that we have a general idea, you should already start thinking about, what could this be, what my options are, and then let's come down to look at the answers next. Or options, sorry. All right, so our options here are different coronary arteries that supply the heart. Each of them have a different part of the heart they supply, and I'll talk about that when we go over the answers. But you guys should already start having a thought process in mind. Which part of the heart is affected and which artery is supplying that part of the heart? So the options include D, right coronary artery, C, proximal left anterior descending artery, B, left main coronary artery, or A, distal left anterior descending artery. Now you see that I came from D and went to A. It just helps me kind of keep my mind organized and not get caught up in the traps. Oftentimes when the question writers write tests, they write it with intentions of you reading from A to D, and usually they lay out kind of traps to make like the second best answer come up right away, so you kind of think that could be the answer. Again, it's not true for all questions, but there are sometimes patterns, and you kind of want to get into the test writer's head when you want to answer these questions. So what do you guys think is going on, and which artery do you think is the correct answer?
Okay, thank you, Abraham. So we have launched the poll. Go ahead and let us know which of those coronary arteries is most likely occluded in this patient. One thing we'll remind you is that on test day, you don't want to leave any question unanswered. So you're not going to get penalized for it. So go ahead and give it your best shot. And especially here during Question Lab, we definitely don't want you to leave any question unanswered. So go ahead and give it a shot. This is, even if you're not feeling all that confident, go with your gut. Sometimes your gut remembers more than you give it credit for. Okay, looks like over 2/3 of you voted. I'll give you a few more seconds, and then I'm going to close the poll. Okay. So 3, 2, 1. Okay, close the poll. Let's share those results. Okay, so right out of the gate, over 50% of you went with answer choice D, the right coronary artery. About 20% of you went with the proximal left anterior descending artery, and then kind of sort of split the third place spot on the podium with between B and A. Okay, so interesting. Looks like we've got a strong contender. Let's hide the results and share the answer. And the answer for question number 1 is indeed answer choice D, the right coronary artery. Well done, everybody. Good way to start off the evening or the morning, as the case may be. But if you didn't get it, that's okay. That's why we're here. We're going to walk through this with you. So, Abraham, you want to take it?
All right. So good job, guys. That was one of the classic we'll run into on STEP. This kind of tests your knowledge about being able to recognize the EKG and looking at the corresponding leads and associating with an area of the heart. Now, this is something that people struggle with very often, but one of the ones that you do definitely need to know is the inferior wall of the heart, right? So 2, 3 ABF are the inferior leads of the heart. Everyone needs to kind of look at this box at the bottom here and generally have an idea of where the leads are. So as you can see here, so 1 and AVL are my lateral, and that's supplied by my left circumflex. My V1, V2 is anteroseptal, V3, V4 is anteroapical, and V5, V6 is anterolateral. So have an idea of how the leads are spread out and which ones correlate with what. The one that's classically asked is my 2, 3 AVF. That's my inferior wall of my heart. That is indeed supplied by my right coronary artery. If you look at the EKG on the left here, if you it's a little small, but you can definitely see it. It's sticking out at you here. If you look at my 2nd, 2, 3, and AVF, you can see that there is an elevation in my ST, right? This is indicative of a STEMI, right? ST elevation to MI. This fits the whole story. It's a middle-aged man coming in with chest pain, shortness of breath, and they give you this EKG. You got to know it's a STEMI right away. You have to call cardiology and activate the protocol. This is one of the things that, bread and butter medicine and bread and butter cardiology, you need to be able to recognize. Now, they can ask you any of the other options as well, but you should be aware how they separate and which leads correspond to which part of the heart and which part of the heart corresponds to which artery. Classic question.
Okay, very good. Again, that's a great start for tonight's session. We'll see if the questions build in difficulty. Let's go to question number 2. So once again, what do? We cover up those answer choices, and then we read the lead-in. And again, as is the case with a lot of cardio questions, we've got an image to go along with this. So we're going to start by reading the lead-in. Which letter on this pressure volume loop in normal cardiac cycle represents, in an otherwise normal person, opening of the valve involved in this patient's condition? So knowing what it is you're looking for, let's go ahead and read the vignette. A 38-year-old woman comes to the emergency department because of increasing shortness of breath and fever. She has a history of injectable drug use. Temperature is 39.2. Physical examination reveals pulmonary crackles. Cardiac auscultation reveals a hollow systolic murmur, obscuring the first heart sound and best heard at the apex. The murmur does not change with respiration. So again, which letter on this pressure volume loop represents, in an otherwise normal person, opening of the valve involved in this patient's condition? Think about that. You can head down to the question box, let us know how many steps you think it's going to take to solve this one as I pass it over to Abraham.
All right, so definitely think about how many steps this will take. This is another classic question. This kind of chart or graph you see on the right here is one that you will see all the time. It's the pressure volume loop of the heart, and we mess with it a little bit. This is our standard, being able to know what the normal is before we mess with it, before we make it go right, left, taller, smaller. Each of them have a correlation to a different condition or a medication. But in this question, they kind of want to know, okay, a patient has an issue, right? And we're going to look at some of the keywords that's going to be highlighted in this, and we're going to use that to help us understand what the patient has. And compare that to a normal physiological situation and connect the valves, in a sense, okay? So we have a 38-year-old woman. So it's a young middle-aged woman who came in with shortness of breath and fever. That's high yield. Injectable drug use, right? So whenever you think of IV drug use, you have to think about many different conditions that are associated with IV drug use. She does have a fever and a hollow systolic murmur. Now, hollow systolic murmur can mean a couple of things, and you should have that thought process go in your mind as well. Now, what would help organize my thought process? Okay, I hear the heart sound best at the apex of the heart. Apex of the heart should also mean something to you. Now, using that information, you should have that the 38-year-old woman, you should have a diagnosis built up in your mind for her. And once you have that, now you look at the normal patient. And you look at this chart, and you see A, B, C, D, and E. These are different points on this pressure volume loop that represent different things that's occurring in the heart. And your job is to know, okay, the valve that's affected in this patient opens at which point of this. Again, I'm going to get you guys get a chance to digest what's going on. Make sure you guys look at where A is, where B is, where C is, where D is, and where E is before we pull the options up, because the chart's going to go away. So make sure you guys, understand the overall situation. If you don't know it, still feel free to guess. We're going to talk about this in more detail. Okay.
Okay. So as Abraham noted, you want to look at that. Think about, choose your point. Choose the point that that you think represents where the opening of the valve would be involved in this patient, and I'm going to launch the poll and just go ahead and let us know. Was it point A, B, C, D, or E? Okay, I am going to close the poll. Looks like 3/4 of you have voted, and let's reveal the results. So again, about half of you made a selection. You went with point A. About 1/4 of you went with point B. So down there on the bottom of the pressure volume loop. Some went with C. Some went with D. A couple of you went with point E. Interesting. So let's hide the results and share the answer. And the answer is indeed point A. So again, well done, everybody. A lot of you understood what's going on there in the pressure volume loop. If you struggled with that one or got confused, that's okay. This is the time to be confused, because we're going to work to clarify it for you. So Abraham's going to do that right now.
Awesome. Great job, guys. So again, this one's a little bit trickier than the last one, but I think understanding physiology is what happens in this question. So recognizing that this is a graph and you're dealing with a pressure and volume loop, understanding what is happening at each of the points, and as you see in the picture on the right here, recognizing, the cardiac cycle. When does the ejection occur, when does filling occur, what valves are opening at what point. And remember, we're talking about the left ventricle in this situation. So this is all centered around the left ventricle. Now, let's go back to the patient here. So we have a 38-year-old woman with injection drug use. When I start thinking about that and coming with fever, my diagnosis should be infective endocarditis, right? So if someone's having a new cardiac murmur, has a history of IV drug use, and has a fever, that is classic situation for infective endocarditis. Now, which valves are affected? Well, when I think about infective endocarditis, the most common I'm thinking is tricuspid. If it's not tricuspid, it could be mitral. Those are the way I think about it is if I'm injecting a bunch of bacteria into my bloodstream, the first valve it hits is going to be the tricuspid. That's the one that will most commonly be affected. But in this situation, they make sure to tell you that it's heard at the apex of the heart. So that shifts it from tricuspid to a mitral valve. Now, am I dealing with a mitral regurgitation or a mitral stenosis? And that's when understanding that the systolic and diastolic and the tricks behind it, that comes in handy. Again, you don't need to know that in this question in particular, but it's always good to have a good diagnosis built. So the diagnosis for this patient is a mitral regurgitation secondary to infective endocarditis from IV drug use. That's part one of the question. Now, part two is where on this chart is the mitral valve open? So let's look at these letters real quick. So we have A going to B. That is the ventricular filling. That is diastole. As you can see, the volume is increasing as you go right. Pressure slightly goes up. Okay. In order to fill the left ventricle, the mitral valve has to open in order to fill the left ventricle. So A would be where the mitral valve opens. Once it's filled, then the mitral valve closes. That's B, and that's where S1 is heard. They love to ask that as well. So this is not just for this question. This graph can be correlated with many, many questions that they can ask about. Going from B to C, isovolumetric contraction. As you can see, the volume does not change, but the pressure increases. So all the valves are closed, but you're contracting the heart. At point C, the aortic valve opens and systole or ejection occurs. As you can see, the volume is decreasing. It's going left. And then at D, the aortic valve closes, and then you isovolumetric relax. That's very important to recognize the cycle and how we mess with it. As the questions get harder, you will kind of have a good base understanding. If you don't know this base knowledge, the much harder, like the 260 level questions that you're trying to get right, you won't be able to get it right unless you know this base level.
Okay, excellent. So, did you have one more thing there, Abraham?
No, so I was just saying, good job, guys, on getting this one right. Definitely will come in handy for future questions.
Okay, very good. So again, nice work. We're about halfway through tonight's session. You guys are doing a nice job. And also appreciate all of the questions and feedback in the question box. Lots of good stuff there. We are recording tonight's session, and we will be posting it on our YouTube channel later this week. What I'm going to do is I'm actually going to put the Question Lab playlist in the chat. So again, you can go ahead and make note of that, flag that, subscribe to it, whatever you want to do. We've been doing Question Lab here we started doing this back in 2020. So we've got quite a few episodes up there if you want to dig into other topics. Okay, so with that, we're going to head towards question number 3. Okay. And again, what are we going to do? We're going to cover up those answer choices. And then what are we going to do? We're going to read the lead-in. Which of the following physiologic responses would occur if the contraindicated medication were given? Okay, that's an interesting one. It's, I love these types of lead-ins, right? Because, and I definitely, advise reading these types of lead-ins, for these items before you go to the vignette, because, this one almost like folds back on itself, right? So now that you kind of know what it is you're going to be trying to solve, let's read that vignette. A 54-year-old man comes to the emergency department with acute chest pain, nausea, sweating, and shortness of breath. The patient has a history of recreational drug use in reports using cocaine, heroin, and alcohol earlier in the day. Temperatures 36.1, pulse is 101, respirations are 22, and blood pressure is 150/100. The medication typically used to treat this acute condition is currently contraindicated for this patient. So again, which of the following physiological responses would occur if the contraindicated medication were given? Head on down to the question box. Let us know how many steps you think it will take to solve this one as I pass the baton over to Abraham.
All right, exactly like how Jeff mentioned, this is one of those questions where you have to read the lead-in to really understand what they're asking. You don't want to do all the hard work and get to the answer, but because you didn't understand what the question was asking, you picked the wrong answer. So let's go through this. Let's look at what the important steps are, or what's highlighted keywords in this question. So, a 50-year-old man, chest pain, nausea, sweating, shortness of breath. Again, few differentials that come into mind. Again, this is another patient who has recreational drug use, including cocaine, heroin, and alcohol earlier today. Pulse is high, respirations are slightly high, and his blood pressure is also elevated. Now, you have somebody who's tachycardic and hypertensive, so what should I give this patient? And why are they making such a big deal about whatever I give him, what can I not give him? And really, that is where this question is really getting at. This is testing kind of your basic science knowledge and combine that with cardiology and understanding what's happening kind of at a cellular level. And I'm going to talk a little bit more about this, but again, I want to give you guys the chance to pick the answer and really think about this yourselves before I tell you my side or why that is the case. So let's look at the options and let's figure out what's going on. Think about how many steps this would take and think about what drug this could be, and then think about what the effect of the contraindicated medication would be. All right, let's look at the options here. We have option E, unopposed vascular smooth muscle relaxation. Option D, unopposed vascular smooth muscle contraction. We have option C, unopposed cardiac muscle relaxation. Option B, unopposed cardiac muscle contraction. And option A, unopposed bronchial smooth muscle contraction. Again, the wording is tricky and there's a lot of similarities and options here. You want to think about what drug we're talking about, what the effect of that drug would be, and why it's contraindicated in this patient and what's happening. Take a second, read over the question, and come up with an answer.
Okay, so everybody, you've got your marching orders. I am going to launch the poll. And I want you to tell us which of the following physiologic responses would occur if that contraindicated med were given to this patient. Okay, so what I'm going to do is I'm going to close the poll. And let's share the results. So, unlike the previous two questions, we don't have such a broad consensus for this item. About a third of you, a little over a third of you, went with option D, which is unopposed vascular smooth muscle contraction. And then, answer choice E, unopposed vascular smooth muscle relaxation, and answer choice B, unopposed cardiac muscle contraction. Both got about the same number of votes. And then answer choice A got some votes, and even the lowest vote getter got double digits, at least in terms of percentage. So very interesting. So with that, I'm going to hide the results, and I'm going to reveal the answer. And the answer is answer choice D, unopposed vascular smooth muscle contraction. So another win for you guys, another win for the Question Lab crowd. That's great. Obviously, a few more of you didn't get that one right, and no shame. These are some tough questions. So what we're going to do is we're going to see if we can help shine a light on this one as I pass it back over to Abraham.
Awesome. Great job, guys. Again, this is a much tougher question or higher level question than the previous two, but it is very high yield. This tests not only your pharmacology knowledge, this tests your understanding of the basic science physiology that's going on in the heart, and really what drugs we use for what. So let's kind of understand what we're talking about here. Does anyone have any idea what drugs they're talking about or what class of drug they're talking about? Someone comes in tachycardic and hypertensive, a lot of the time our reflexes are to give them a beta blocker. I think, when somebody ever asks you, like, hey, my heart rate's really high and my blood pressure's up, what can help control both? Well, a beta blocker or calcium channel blocker. Those are options that we always think about using. Well, in this situation, that is contraindicated. Does anyone know why it's contraindicated in this situation? So wait a couple seconds. So I see propranolol beta blockers exactly. And why would it be contraindicated? What in the patient's history makes it contraindicated? It's his cocaine use. So the cocaine is the big no-no for beta blockers. Now, why is that? Now, this gets down into the weeds of it, but you guys have to know this because we have to think about how cocaine works, right? He's got few exposures, cocaine, heroin, alcohol, but cocaine is the big one that's causing his current symptoms, his tachycardia and hypertension. Now, cocaine, we know, prevents reuptake of norepinephrine and epinephrine back into the neuron. Now, if a bunch of norepinephrine, epinephrine is floating around in the synapse, it can bind to different receptors, my alpha-1, beta-1, and beta-2. Now, if I give someone a beta blocker, it's going to selectively block my betas 1 and 2. So what's left over, right? We're playing musical chairs, and there's 3 chairs available. Your alpha-1, beta-1, and beta-2. And your norepinephrine and epinephrine like to bind to all of those. Now, if I take away my betas, it's only going to be able to sit on my alpha chair, or only going to be able to bind to the alpha-1 receptor. And alpha-1, as we know, causes vasoconstriction, right? Vascular contraction. That's the big issue, right? The patient is already hypertensive. Sure, if I give them a beta blocker, I can slow the heart down a little bit. I can bring that 101 heart rate down to 80. Okay, fine. But that blood pressure will go up even more. And it can cause strokes, it can cause big issues like that. So beta blockers are not the way to treat cocaine-induced tachycardia or hypertension. Those are absolutely contraindicated in those situations because even though I'm going to help slow the heart down, I'm not blocking the alpha-1 coming from that norepinephrine increase due to cocaine. Again, tricky question here, but really, if you see the full picture, it makes a lot of sense, and this is something that you don't want to forget. When you're doing rotations, your doctors love to test you on this, especially in the ED, especially in the ICU. They will ask you, it's like, hey, you see someone with cocaine positivity, and they'll say, do you want to give this guy a beta blocker? Your answer should be no. And really, I hope you take away from this and kind of sticks with you for a long time.
Excellent, thank you, Abraham. There you go. Good clinical pearl to stow away. So again, great job, everybody. And we are now here at question number 4. So this is the final question of the night. You guys have done a nice job, and I want you to close strong. You got to close strong on step day, right? When you're going through that from first question, first block to the final question, the final block, you've got to be able to keep that stamina up. So hopefully you can bring all of your focus, all of your attention here to this final question for tonight. Okay. So again, we've covered up these answer choices, and we're going to read the lead-in. Which of the following is the most specific ECG finding for the disorder most likely causing this patient's low blood pressure? Okay, so again, there's a lot happening there in that lead-in, and hopefully that will help kind of train your eye on the details that you need to pick up and parse to answer this one. Okay, so with that, let's read the vignette. A 75-year-old woman with advanced esophageal cancer comes to the emergency department reporting several days of dyspnea and chest pain. Blood pressure is 80/39. While measuring the patient's blood pressure, a practitioner finds that Korotikoff sounds are heard only during the expiratory phase. After a drop of 15, the Korotikoff sounds are heard throughout both the expiratory and inspiratory phases. Physical examination reveals jugular venous pressure is 14 centimeters. Normal is 6 to 8. So again, Which of the following is the most specific ECG finding for the disorder most likely causing this patient's low blood pressure? Head on down to the question box. Let us know how many steps you think it's going to take to solve this one. Is this a 1-step, 2-step, 3-step? As I pass it over to Abraham.
All right, so we have another tricky one here. This was a high yield question, and one that you will be asked something along this realm of possibility on your exam. So I'm going to go into what really breaks down in this question. What's high yield in this question, right? So we have an old guy, 75-year-old woman or female, sorry, with advanced esophageal cancer. Okay, cool. She's got dysphagia and chest pain. Blood pressure is low, 80/39, and they kind of mentioned this heart sound situation, right? So what are these corked cough heart sounds, right? Whenever I see a big fancy word I don't recognize, just kind of, you can even just ignore it, right? It's heart sounds. That's all it is. It's my S1, S2, right? So it finds that the heart sounds are only heard during the expiratory phase. Now, after drop in 15, then they hear them in both expiratory and inspiratory. Okay, so we're going to talk about what that indicates and what's important from that phrase there. And on physical exam, you see jugular venous pressure of 14, right? There's jugular venous distension in a sense. It's more than 8. Now, again, think about the steps, right? First, based on that first paragraph, diagnosis is the key. Think about what the patient has, what caused that to happen, and what are my clues in this question that points towards it. And part 2 is, okay, what EKG findings can I see in this patient that's most specific for the disorder, not just a random EKG finding. You got to think about what's going to be pathognomonic for this condition. All right, let's look at the options here and kind of break down what's going on. 5 options here, A to E, and each of them correlate with a different condition, and each of them correlate with different pathognomonic things we should be aware of. So let's go through these options here. So option E is QT prolongation. Option D is peak T waves. Option C is prolonged PR. Option B is a diffuse ST segment elevation. And option A is alternations of QRS height with each beat. Now, each of these have a different correlation with a different condition. I'm going to go into that. I'm going to tell you, hey, what does this represent? What does this represent? And you should be able to think about what is associated with, right? So your key in this one is diagnosis based on the first paragraph, and then making that connection to that EKG finding that's most specific to this condition. Understanding that the patient has chest pain, dyspnea, and a history of esophageal cancer. All right. Now, take a moment, look at the options, look at the question, and go for the answer.
Okay, so we're going to launch the poll. Again, this is the final question of the night. So let us know which of these is the most specific ECG finding for the disorder, most likely causing the low blood pressure in this patient. And we're going to go ahead and close the poll. Okay. So let's share the results. So, this evening we had a couple of questions where we had almost 50%, over 50% answering the top choice. Question number 3 was a little more split. This one, definitely, more of you went with option A, alternations of QRS height with each beat. About a quarter of you went with PR prolongation. And then answer choices B and E got about the same number. And a few of you went with peaked T waves. So a good, interesting spread. I'll tide the results and share the answer. And the answer is answer choice A, alternations of QRS height with each beat. So congratulations, you guys did it. You went 4 for 4 tonight, and that's tremendous. Especially we had a couple of pretty tough ones in here. But if you didn't get this one, that's okay. Or if you got this answer right, but you just felt lucky, that's okay. Luck does play a part, I think, in some of these exams. But either way, we're going to help you understand how to get to the right answer if you didn't. And to do that, Abraham's going to show you the way.
Awesome. Thank you, Jeff. So Again, great job, guys. Another tough one, but very high yield. Now, can anybody in the comments say, what the diagnosis is, right? So we have somebody with a history of esophageal cancer with hypotension, jugular venous distension, and there's one more finding they didn't mention here because we make it too obvious, would be muffled heart sounds, right? That is, those three things together should be my Beck's triad. This is a typical story. They'll give you 2 out of the 3. So often Beck's triad is going to be my hypotension, my jugular venous distension, and my muffled heart sounds. Now, when I hear muffled heart sounds, right away I'm thinking the diagnosis of cardiac tamponade, like a lot of you guys were saying, which is correct, right? And again, the cardiac tamponade here is secondary to the underlying cancer, leading to a pericardial effusion. When the pericardial effusion gets big enough or grows fast enough, it causes a tamponade. Now, the tamponade, imagine the heart floating around in a bag of blood. The pericardium surrounds the heart, usually has a little bit of fluid in there, but not very much. But when that fills up, it's a big bag of fluid that the heart is floating around in. The heart should be sitting still in the heart, in the chest cavity. Your heart is not moving around normally. But when I have that fluid surrounding the heart starts moving back and forth in my chest, and that's what caused a lot of these findings. So let's get into some of the key things that comes out of this question. Definitely very high yield. I had multiple cardiac tamponade questions on my exam, and all the students I've taught, I've always said at least 1 or 2, and you have to know this. So cardiac tamponade is top of the high yield for cardiology. So again, you have hypotension, JVD, and muffled heart sounds. Those are my Beck's triad. So you have 2 of those here. Now, what are my extra findings? So there's 2 bonus findings in addition to the Beck's triad I always teach my students. Number 1 is this heart rate situation they're talking about here. Hearing the heart sounds only during inspiration. And they talk about the drop in blood pressure. You hear them both, okay? Now, the technical definition for this is a term called pulsus paradoxus. And I'm sure you guys heard this before, but what is pulsus paradoxus? Pulsus paradoxus, by definition, is a drop in systolic blood pressure by 10 millimeters of mercury during inspiration. Now, that's not always feasible in real life. Are you going to take a blood pressure during inspiration and expiration and compare them? Less likely. What's more likely to happen is the way they'll describe is pulsus paradoxus, the pulse part. During inspiration, when my systolic blood pressure drops significantly, the gap between my systolic and diastolic will reduce. So that's called pulse pressure. When I have a reduced pulse pressure, my pulses will disappear during inspiration. So the other way that they'll describe it is loss of pulses during inspiration. But in this question, they say, can hear the heart sounds during inspiration. So that is the same idea. They're trying to kind of hit it different ways, make sure you understand it, not just memorize it. So that is pulsus paradoxus. So here they have 2 of the Beck's triad with pulsus paradoxus. And that should guarantee you to think about cardiac tamponade as the diagnosis. All right, so that's part 1. Coming up with a diagnosis, a big part 1, but it's part 1. Now, how can I connect that to an EKG finding or ECG finding? Let's go through these options, right? These are high yield options. They all point towards different things, and we'll go through it. So let's start with E and work our way up. So E is QT prolongation. We know QT prolongation is very high yield to know as well. It's a typical EKG finding associated with many drugs that we talk about. A lot of the antiarrhythmics, antipsychotics, some antidepressants, even antibiotics can cause QT prolongation. And the danger with QT prolongation is that it can go into what's called the torsades de pointes. Again, that's a whole different topic, but again, very high yield. Peak T waves. When I hear peak T waves, think potassium. Potassium is my T wave indicator. High T waves means hyperkalemia. Low T waves mean hypokalemia. That's kind of what they're pointing at there. A PR prolongation. I saw a lot of you guys pick PR prolongation. Now, when I think about these dilators, you got to think about what P wave represents and what the R is representing. The P represents atrial contraction. R, or the QRS complex, represents QRS contraction. So if I base that out too much, that's what we call a heart block, or things like beta blockers can prolong PR. PR prolongation equals heart block, or calcium channel blocker, beta blocker, something along those lines. B, another high yield one, diffuse ST segment elevation. Remember, we mentioned in the first question, ST segment elevation, when it's in those contiguous leads, 2, 3 AVF, V1, V2, that indicates an MI, a STEMI. But if it's diffuse, if every lead on my EKG has an ST elevation, does that mean I have a heart attack or myocardial infarction in all my leads? No. A diffuse ST segment elevation indicates a pericarditis. The entire heart is inflamed. That's why you have that elevation. Okay. Now that would have been a good thought process, but pericarditis is not cardiac tamponade. Pericarditis can lead to an effusion, which can then lead to tamponade, but not in this situation. This situation is a cancer that's leading to an effusion that's leading to a tamponade. Now, option A, alternations in QRS height with each beat. Does anyone know what this term is called? There's like a Latin terminology for this. And it's called electrical alternans. Name gives it away. Electrical means EKG, electric EKG, right? Alternans is alternations. You have a higher QRS followed by a small QRS, followed by a high QRS. The alternations in the QRS height is secondary to, like I mentioned, the heart is in a bag of fluid, so it's swinging around in my chest. So when I have my chest wall leads, the EKG leads on my chest, when the heart swings closer to the leads, the QRS gets nice and tall. When it swings away from the leads, it gets small. So the idea of alternating QRS height indicates the heart is moving around in the chest. That's all that means, and that is a specific finding in cardiac tamponade. So again, just to kind of summarize, it's a tough question, but very high yield. You have to know your Beck's triad, which is my hypotension, JVD, and muffled heart sounds, in addition to my two bonus findings, which is pulses, paradoxes, and electric alternates. Very high yield stuff. Definitely lots of different variations of this question will be out there. Make sure you guys get this down and get it right.
Okay, excellent. So again, nice work, everybody. Loved all of the engagement, loved all of the work that you guys put into it tonight. And again, the crowd went 4 for 4. So we're going to chalk this up as a big win for the RX Question Lab crowd. Go ahead, you can screenshot the QIDs that we used tonight, or write them down. Either way, when you're in USMLE-Rx, you can just go in and put these into the search bar and dig a little bit deeper. So if you wanted to learn a little bit more about the explanations, or if you wanted to see, the express videos, or the bricks that help lay the foundation for some of these concepts, all of that that's available for you if you've got your RX account.